Shockwave reconstructed my entire professional and personal life. Thank you, Shockwave. The second disease to be tested and already tested in some trials is Parkinson's.
Now in Europe, they're using it for brain treatment.
People might come for my surgical expertise, but in fact, they came because I knew how to operate and actually do not operate on them. I could not live without Shockwave.
Today, I have truly a special guest from Germany, Dr. Karsten Knobloch, and I knew you for years as a figure, and pretty much everybody in Shockwave community knows you. But then we met many times and we kind of got to know each other more. And I truly appreciate that you found the time to share your knowledge, your experience with Shockwave as a surgeon to the world. So I'm gonna share something with the public before we start talking. I remember when I came to ISMST conference in Salzburg, Austria, you did a presentation and you showed your clinic, your first clinic. I think it was around like 2013. And I said, oh my God, that's the clinic that that's the concept of the clinic that I had envisioned. So you were very futuristic then. So I cannot imagine now. So if I walked in your clinic tomorrow with pain, what would surprise me the most? How you treat me compared to what I expect to be treated from a surgeon.
So actually, I'm a trained surgeon and I'm board certified as a general surgeon, as a plastic and aesthetic surgeon. I'm a board certified hand surgeon, and I'm board certified in emergency and in sports medicine. But I quit my, let's say, surgical knife scalpel career as early as I started with regenerative therapies, which was in 2006. Actually, I started Shockwave. So it's now becoming my 20th anniversary. And my clinic, which you admire so much from Hanover, started in December 2012. And my approach now is a more regenerative one. So I'm calling myself, albeit I'm board certified in surgical disciplines, as a regenerative surgeon. And I now try to avoid wherever I can the operation. And with the help of my regenerative tools, with radial and focused shockwave, with oscillating magnetic fields, with different lasers, with ultrasonic guided injections, and other tools, I oftentimes can help, let's say, in pain states in musculoskeletal medicine, put it broadly. In the beginning.
That's amazing. That's truly amazing. So you trained all these years as a surgeon, and then now you're building a career in not cutting people. So why and how?
Now there is, always an development and in history, I would say. So I was back in my university days when I was trained in different surgical disciplines. I wasn't expecting to go in a private practice later on, but I was thinking of a university career. And since I moved the departments and I sticked in plastic and hand surgery for 60 years, and I was the vice president of the department. So everybody in Germany knew that I will become a, let's say, department chief in 3-4 years in plastic surgery. However, this was not my favorite interest because I was pretty much in sports medicine. I was pretty much into regeneration. And of note, plastic surgery is always the editor of the plastic reconstructive surgical journals. Rorix from Dallas said, as a plastic surgeon, we don't owe an organ, but we, as a plastic surgeons, own innovation. And in a way, I'm keeping up with the pace. In plastic surgery, you always have to individualize, tailor your treatment, your surgical. There is not like in prosthetic surgery where you have TKAs back and simultaneously, but in reconstructive surgery especially, it is always a single tailored individual approach. And this is what I now do. And then over time, and when I started in Hanover, I had an operation room there. However, I rarely entered it. So only 6, 8 times in a year, I was in my operation room. So I thought people might come for my surgical expertise, but in fact, they came because I knew how to operate and actually do not operate on them. This,
Yes.
the market decided in the end.
Yeah, it's true because there is a saying, and it's just for simplicity. I'm tithing is to the money, but is the paychecker. Who pays, who gives you the feedback, and sometimes as a practitioners, we just get onto that. It's like, okay, we have all this education, we know how to do this, and then this is the way, but we have to listen and decide based on the feedback.
Yeah, actually, and in my surgical career, it was always, since I was changing departments after 2 years, 3 years, 4 years, simultaneously, after consecutively. And
Yeah.
therefore, I often somehow trained and moved to another field, and things.
Yes.
So it is constant. I was constantly moving over my past, say, 25 years now. So I started my surgical career in 2001, medical school, and now it's 25 years later. And I, saw quite a lot, operated from head to toe, nearly everything. And now I'm happy that I have the experience not to operate.
Yes, yeah. This is just amazing. So take me in 2006. Like, how did you discover Shockwave? Like, what triggered you, to choose as a tool? So that's I love hearing that. It's truly
Yeah,
fascinating.
this is in my view a very interesting story, since at that point of time I was already in plastic surgery, but had spent 2, 3 years in trauma orthopedic surgery right
Okay.
before. And during that time, I had a broad scientific interest. However, I studied Achilles tendons in sports medicine, and I discovered by chance the neovascularization with the help of some special microcirculatory ultrasound system, the laser Doppler system. And we found an, let's say, increased vascular blood flow at the point of pain in mid portion and insertional Achilles tendinopathy. So there was some upregulation of vascularization. And then I did studies on eccentric training and other measures. And at that early time, 2004, 5, 6, it was already published that shock waves can help tendons to heal. Early studies. So I said, okay, since I had quite a lot of money in my research lab, and I asked my chief whether or not I could buy. He said yes, but you can only buy either radial or focus. And then by chance, I chose events, because at that point of time, there was no internet community on Shockwave. There was no ISMST big meetings. There were some, but minor meetings.
Yeah.
There was no online education. Zoom was not invented. There was nothing. So I, by chance, saw an advertisement of a German distributor, and he distributed Storz devices, and I drove to Leverkusen, which is in the western part of Germany, 3 hours away. And the former founding member of German Shockwave Society, Diges, was my first, by chance, trainer. And he was interested in the Achilles tendon as well. So I did, like a normal customer, a workshop on a weekend and spoke quite a lot with him, because I saw described the vessels and my observations and things. And then I tried radial and focus. And at that point of time, the radial machines had the lowest energy was 2 bars and a steel applicator. And then I tried it with some ultrasound gel, and it was very painful. And with the focus device, I could really be very soft with this gel. And I said, okay, since there is some studies on radial, some studies of focus, and my chief said I'm allowed to buy only one machine. I said I go for focus. And then, just by chance, then for the next 6 years, from 2006 to 2012, I was only performing focus shockwave, and I came then by chance into contact with the ISNST guys, and there was a big fuss on radial or focus. We did not know that the combination, which we know now,
Yes.
now is much better than separate. But at that point of time, it's
Yeah.
20 years ago, we did not know. So there was kind of a conflict, and different companies providing either radial or focus. My company was the only to provide both, but by chance, I was
Yes.
in the party of the focus group.
Yes.
And,
Yes. Yeah.
I was only interested in focus at that point of time. And that's how everything started. And then my first patient to treat it with shockwave in plastic surgery then was a lederhose patient. So a female who was operated by my chief half a year ago for a lederhose nodule on the foot sole, which was very painful. And then by chance, it came back within 6 weeks. And my chief was at that point of time the head of the German Surgical Society, But still, in this kind of disease, this a recurrence might occur. And it happened. And she said to me, you can do whatever you want, but do not operate. I said, okay, I heard about the shock waves might be good for heel pain in plantar fasciitis, heel spurs. I said, why not give it a try? She said, yeah, why not? And then I did one treatment. Then I said, come back next week. We're going to see. She said, yeah, it's a bit better, but not that much. I said, okay, we do 3 treatments like in plantar fasciitis and then wait. And then she came back at 6 weeks, at 12 weeks, and the pain decreased gradually by 50%, by 75%. I said, oh, interesting. The nodule itself was solid, a bit softer, but size-wise not changing tremendously, but pain-wise it was tremendously. And then I said, okay, very interesting. And since in plastic surgery we have hand surgery as well, and in northern Germany we see and are operated on 3 to 4 Dupuytren patients in a week, so it's quite frequent.
Yeah.
I then collected all the lederhose patients and started with shockwaves on lederhose and on Dupuytrens. So these were the first 2 diseases to be treated by.
Oh my God. Wow. Wow. And then you did a publication on those 2 conditions, correct?
Right. So I
Yes.
started on lederhose, collected some cases. So a small cohort study in the beginning thought that similar to this, let's say, destroying a kidney stone, I thought that I might destroy somehow the nodule in Dupuytren or in lederhose disease. That's why I played around with energy. So I went high on my machines and tried everything, more energy, more shots and everything. But, after now 20 years of experience, I can tell you I cannot disrupt either with
Yes.
radio
Yes.
focus a nodule after 20 years, but I can change the course of the disease because it seems that the shockwave can somehow stop or at least decelerate the progression of the disease in
Yes.
fibrosis. We see it in scars as well nowadays, and we have even very good experimental data supporting the idea that shockwave can modulate or be even antifibrotic. So somehow release and get it softer. And what we saw in Dupuytren can really change quality of life in the affected patients. So, and I know in Northern America is still available the collagenase injection with Cyaflex, which I did from 2012 to 2019. And then it was, not distributed outside of the US anymore. And I combined all, and this was, in my view, the best combination for, at least for Dupuytren, with a cord and contracture to do the injection and shockwaves to reduce the side effects of the injection with swelling, with pain, with hematoma
Yes.
and things. Yeah, that's how I actually started.
Wow. Well, it's interesting because listening to you 10 years ago, like I've been doing shockwave since 2011, and I started first with radials, then I did focal, and being in private practice, you get paid based on results. You don't create results, you don't get clients. So you're kind of forced to outperform. But
Right.
I'm gonna pick your brain on this because for over 10 years. So 10 years ago, 11 years ago, I took a training in neurokinetic therapy, which is testing how the nervous system gets the sensory input. And then based on that, it decides motor response. And when I was 5 years old, I had a hernia surgery. I was a competitor swimmer, cyclist. I always had bigger belly. And when I took this training, they taught us that if you have a surgery because of the fascia being cut, because of scar tissues, adhesions, pulling in the muscle, it doesn't allow the muscle to contract properly, but also it affects the sensory input of the brain. Like the brain doesn't get sensory inputs and therefore it doesn't respond locally there. It kind of goes global compensation. So I thought, oh my God, I can do this with Shockwave in a matter of seconds because they said massage the scar, do this. So I tested on myself. And 6 weeks later, people were telling me, "Oh, you're working out, like your belly is down." It's like, no, I haven't done anything. It's something to do with a shockwave. So then I start experimenting, with clients, like treating every single one who had surgeries, especially C-sections. So now I've done like thousands of them. So if somebody walks in at Unpain Clinic, if they had any kind of surgery, we go and do shockwave. Doesn't matter how long it is. And we have learned that it activates the muscles, it restores the communication. It's interesting because this is what we explain. And then we want you to teach us a little bit more on this. I always tell clients is when you have a surgery, whatever it was done inside fixed, that initial problem why the surgery was done. But the fact that the soft tissue, the fascia, the skin, it's cut, the body cannot tell the difference if you cut it intentionally or not intentionally. It's going to respond with the same mechanism that it responds to the injury. So it creates all those side effects. So from all the surgeries that you've done, like how often do you combine it with shockwave, or like what is your approach after the surgery?
So seeing that the shockwaves could help in my surgical OR, I started actually in 2006 because in plastic surgery, we oftentimes were consulted for scar treatments, as you know. So I had
Yes.
very refractory keloids wherever after laser, after ablation, after everything. So this were with one, let's say, very early indication. And I had to operate, let's say 2008, 2009, one or two free flaps, surgical free flaps per week. So quite a lot. And I
Okay.
was not a big fan of microsurgery because it was so tedious, very tiny things and very complicated. And oftentimes you end up with some vascular problems, especially on the venous side.
Yes.
And I tried to improve my surgical flap results with pre-treatment of my flap. So in the OR, when I harvested the flap, I treated it just before I transferred it. So it's called preconditioning. With this preconditioning, I could significantly reduce my complication rate being 2 or 3 nights later in the OR quite tremendously to a niveau and to a level to which my chief had, which is a very experienced microsurgeon. So my
Yeah.
shockwave machine helped me in a way, and I can now tell it because it's 20 years ago, to be
Yeah.
a better surgeon because, I had the machine in addition because complications were less. So that's how I started 20 years. So I would, and each and every operation I did in my practice from 2012 was, let's say, associated in the beginning with shockwave and now with shockwave and the magnetic field because I see earlier healing, less lymphedema, less swelling,
Yes.
less scarring, less pain medications and others. So I believe for the future, and this is an initiative which is even enforced by my friend, and you know him, Wolfgang Schaden, who is the president of the
Yes.
ISMST. And I just came back last week from the biggest or second biggest German ortho trauma surgeon meeting with 3,000 participants. And we had a session on shockwaves in cooperation or in association with surgery. So I talked on shockwaves in hand surgery. We had it in coronary artery bypass grafting. We had it in aesthetics. We had it in ortho. We had it in prosthesis. So we had just collected a session only on your question, combining surgery with shockwave to have better results and less complications.
So how soon could a person get shockwave after surgery typically? Is there any timeline?
So if it's, in my view, an elective scheduled surgery, I would at best treat at least once before the operation, because there is even data from Austria for tummy tuck, abdominoplastic,
Yes,
cosmetic
yes,
surgery,
yes. Yeah.
where they did on the day before surgery, half of the abdomen where the scar will be with focus shockwave and the other was placebo. And then they looked at 6 weeks and 12 weeks and found a better scar where the shockwave was done on the half of the abdomen. So therefore, there is good data for preconditioning before. And
Yes.
there is even data by Rainer Mittermeier, you know him well from Salzburg,
Yes,
who was the
yes.
conference president
I
2013
know,
in
I
Salzburg.
remember that. Yeah. Yeah.
Yes, and he did a lot of studies in rats, experimental studies on flaps, and he did it either before, immediately after harvesting, or even 24 hours after harvesting. And the best results were seen just before or right after, and
Yeah.
less good results 24 hours, but still good results 24 hours after. So I would say, if a patient, for whatever reasons, comes after the operation, I would start as early as I can, even if it's only 1 or 2 days, because you can, if you have a sterile issue, you can use sterile gel, put a foil on,
Yes.
and then do the shockwave like in open wounds. And the sooner you do it, and we see even microbiological effects. So we have kind of similar to an antibiotic, we can create or crack bacteria. We can crack biofilm, which is protecting the bacteria from antibiotics. And there's a radial study showing that radial can crack the biofilms up to 50%. So this is quite significant. So I see a strong, let's say, strong partnership in early shock waves and better results after whatever surgery you have.
Yeah, that's amazing. Okay, so this is like somebody's listening, is following here, and it could be a clinician or it could be a human in pain, but they
Yes.
never heard about shockwave. They don't know what the hell is this technology that everybody's talking about. It's so beautiful. We have a surgeon talking about it. How do you explain to somebody what is shockwave and what it does and how it works?
Yeah. So in the end, it's a medical device, and we position or classify the shock waves as an energy-based therapy. Energy based therapies are, on the one hand, shock waves, which are using, in a way, acoustic waves. You can hear them, you can feel them. We have lasers, which are using optical physics for
Yes.
photobiomodulation. And we have magnetic field, fast oscillating magnetic fields, either pulse electromagnetic fields, PEMF, or extracorporeal magnetotransduction therapy, EMTT, which are using magnetic fields. And even, say, vibration therapy with the Theragun, for example, or with the Viector, is kind of an energy-based therapy as well. And
Correct.
all of
Yeah.
these energy-based therapies, have in common that they are non-invasive, they won't hurt the skin, and they will somehow accelerate healing on different pathways, I would say. And that's the reason why we now see that if you are really smart, you combine all these machines to have even stronger results, because in the end, the healing is better. But if you influence the healing of a tissue after, say, a bone fracture or after tendon rupture or whatever, on different pathways, you will end up with better results faster. So I'm saying these devices really help quite tremendously, and they are non-invasive. That's why it's placed in my, let's say, sequence of therapy
Yes.
before a injection, for example, because it's completely non-invasive. In tendons, for example, I start with training, load optimization, kinesio, cryo, whatever, and then energy-based therapy. And if not enough, patients not satisfied, then I proceed to another stage. For example, more invasive being ultrasound-guided injections, for example. Or in
Okay.
carpal tunnel, the same. I start energy-based. Then, if not possible, then I go for ultrasound-guided hydrodissection, so special injections around the nerve. And if this is successful, fine. If not, then I proceed to the OR for open surgery. So I would say these are very early, pretty powerful energy-based devices, which help the patient or can help the patient quite a lot. they cannot always help in each and every case for 100%.
Yes.
So
Yes.
there is kind of I would say, success rate depending on disease state, severity, patient's factors like age, smoking, perfusion, timing, optimal dosage. There is quite a lot, in my view, in shockwaves of a learning curve with the operator. There's much less of or much steeper learning curve because it's much easier to perform a magnetic field therapy or laser therapy because you don't have that much of adjustments in a laser, typical in a laser machine or in a magnetic field machine, and much more options, especially in radio, even more than with focus. If you see frequency and pressures, and if you multiply it, so, and applicators. So, therefore, I strongly believe that a proper learning and a continuous learning experience, that's why it's called CME in the end, continuous medical education, is paramount. And I still, doing now 20 years of Shockwave, learn with each and every patient to become a better operator in the end.
Yeah. It's exactly it. Like, it's in the end of the day, it's a tool. So it's going to perform as good as you know how to use it. In Europe, there has been regulation, for a very long time, like 20 plus years. Unfortunately, in North America, there's no regulation. Like, I'm in Canada, I contacted the College of Physiotherapists and I said, hey, you guys need to regulate this because you have practitioners buying devices, zero training. They're claiming that they're doing shockwave. And we have so many even cheap devices that are coming, from China. They buy it on Amazon. So it's just kind of a truly wild west. And then it damages the field because I know how beautiful, how powerful, how good shockwave is to stimulate human body to heal itself. So yes, it's not going to solve everything, but it's that factor that gets the body to heal itself. So, and yeah, we know like the problem with the training. Now there's a lot more. Like ISMST is the International Society for Medical Shockwave Treatments. In Germany, you have DGEST, and then there's like other organizations. There's lots of trainings available. But one thing that still kind of scratches my brain is like, why more doctors are not using shockwave? Or how is shockwave, in medical community in Europe? Because I know how it is. Like in North America, it's not doctors that use it. It's more PTs and chiros. And now there's some, pain doctors that are just entering that. Do you have any comment on that?
I can. So it is legal-wise and development-wise, country-wise, totally different. So if we look back in history, and we still believe that by numbers, Germany has the biggest shockwave community. So the German Shockwave Society was founded in 1995, 2 years prior to the ISMST. And the idea at that early days was to, on the one hand, to examine the power of the shockwave, but to clearly find or propose regulations and provide education, because it's very powerful. However, it can be misused for sure.
Exactly.
And therefore, in Germany, and this is still true in 2026 and 2026, a focus device can only be operated by a physician. Period. Full stop. Radio devices can be applied by non-doctors like physiotherapists, chiros, whatever, after a proper training, but focus is not. The same is true in Austria, and there is even a legal, let's say, comment on this. So it's by law for Germany and for Austria, focus is done by physicians only. If we had 300 kilometers westbound to Amsterdam, Netherlands, where we had the ISMST meeting 3 years ago.
Yes.
We have a very, very vivid and good national Netherlands Dutch Shockwave Society. And this is run by physiotherapists mainly. There's only one physician in it, Marianne. Others are only non-doctors. And they have, for example, a very dense network of physiotherapists with more than 40 locations. It's a very small country for
Yes.
shockwaves in spasticity. So they are very, very good. And why is it? And they said the orthopedic surgeons are very interested in operations because of reimbursement.
Yes.
And they were not interested in seeing the patient before or after the operation. Usually, at least in the Netherlands, the physicians were not so much interested in rehabilitation. So the patient was discharged after the OR in the hands of the physiotherapist. And then they just let it be, the physicians. And that's how in a lot of countries, the same is true in United Kingdom, the physicians, if they are especially surgeons and they are not that much open-minded and very focused on and narrow in their view and perspective in the OR only, they won't see other regenerative tools, or they see these regenerative tools as a potential opponent, either shockwaves or operation. This is the situation. Not end. If we then now can tell them you can reduce your complications, you will have a better patient score, and the patient is happier, they would be good. But there is kind of arrogance or whatever in countries, which then if non-doctors see how good they can perform with these energy-based therapies, that's why, for sure, there are countries, look in the United Kingdom, look in the US, look in Canada, where there is a strong non-doctor driven movement. In countries like Germany, Austria, South Korea, Japan, there is still very much Thailand, very much physician driven. So there are different, let's say, moods.
Yes. Yeah. That's interesting because it's when you brought this up, I'm thinking I built the clinic based on the shockwave. 2011, that was our first modality. And so powerful, and people, because in Canada is the same thing, like surgeons, they just want to do surgery. You wait for joint replacement, probably year to 2 years, people suffering pain, and there's nothing after that. And because we are more muscle skeletal, even though I've done aesthetics and stuff, and we'll talk more about it, but when joint is replaced, the only mechanism or the tissue that is still the same before the surgery is the soft tissue, is the muscles. So shockwave is very important. And when I look back, we have literally people traveling from all over North America coming for shockwave treatments because we were one of the first ones doing it. So it's interesting because patients will look for solution. And they're going to go and find it, wherever it is. But I truly just wish that it will be more incorporated in every aspect of the medicine, because it's one tool that can be used by a surgeon, can be used by physio, can be used by chiro, can be used, in aesthetic medicine, wound healing. Now they do it for men's health. Now in Europe, they're using it for brain treatment, right? Like the TPS.
Yeah, I'm doing TPS since 2020, so I'm doing it 6 years now. So,
oh my God, tell us a little bit more, because this is believe me, it's going to be another 10 years probably till it becomes available in North America. So we need that.
I hope it will be sooner. I started. So let's say, I know Henning Lose-Busch, who is a neurologist from Germany, and he is kind of a pioneer in the application of shockwaves in neurology, I would say. He was the first to show in 1996 that shockwaves are good for spasticity, and he promoted it. Then in the early 2004 or 5, he started to treat coma patients with shockwaves on the brain, with some results, however, published only in German, so nobody outside of German knew. Then he did spina bifida and other neurological paraplegia patients, and they improved. But he applied in these paraplegic patients 40, 50, sometimes 60 sessions. So he used the machine in a clinical environment in a rehabilitation clinic, and they just got it every day, for 2 months, for example. And then he saw pretty good motor recovery. Then first treated, I don't know the date directly because we wrote a book on this, and he wrote the chapter on his brother who had Parkinson's, and he was treating him in the beginning without navigation, and seeing pretty good results. So he could reduce his anti-Parkinson medication, rigor was less, tremor was less, motor function was better. So there was something. And then he came into a discussion with Storz, and then they said, okay, it would be nice to have kind of a navigation tool. And then Storz developed, let's say, kind of a navigation tool. So the patient now undergoes a MRI scan, and the CD with the MRI scan is then implemented into the Shockwave machine. And on the Shockwave machine, there is a camera, PD camera, and two probes. One is placed on the, like in my glasses, on the patient, and the other, a navigation tool, is on the Shockwave probe. So after calibration of your brain, and you see the skull dimensions by the MRI, you can see in three slices or perspectives in real time, if you put it on, where you are and where you're heading at. Because then, depending on the numbers of shots you place on one location, the color changes. And then it's like a coloring book. If you want to treat the entire brain, go everywhere. If you go in Parkinson's, for example, for different locations, nucleus subthalamicus, small brain and others, you go there. If you go lymphatics, you go there. If you go for visual loss, you go there. And that's how the idea of TPS is.
Wow. So how successful it is, or is it going to cure the condition? Is it going to reduce the symptoms, or what does it do to the brain?
So in Europe, the first trials were done in Alzheimer's. And the trial which led to the CE, also the European approval of the machine, similar to the FDA in the US, was done in Vienna for mild to moderate Alzheimer's disease. And they could show a significant reduction of or improvement in the functional scores in early to medium or moderate Alzheimer when they apply 6 sessions in 2 weeks. So you do 3 treatments in a week every second day, 2 weeks in a row, and then after 4 weeks, you do let's say, a refresh treatment. And then depending on the treatment response, you will follow up the patient for every 6 weeks or every 3 months. That's the usual pattern. And then usually lifelong. You cannot cure the disease, but you can obviously significantly improve the outcome quite tremendously. Although in my personal non-neurologist view, I did some neurosurgery, but I'm not a neurologist. It is a pretty hard disease to treat, because look how big pharmaceutical companies, Pfizer, Eli Lilly, and others, fail with the development of medication in Alzheimer's disease, because it is simply a very, very hard disease in my view. And we oftentimes treat far too late. So I think the interest in the early detection of the disease and then maybe early treatment would preserve brain function much more, seeing now that if the disease is not moderate but severe, have universally, because there are more than 100 TPS machines worldwide at the moment, you see not good results if it's pretty progressed already. So you have to be early, And from my early days in 2000, I still have patients who still come every 6 weeks or every 3 months, because they pay self-pay for it, because it's not covered by insurance. But they are so happy that it somehow tries to restore or at least preserve memory function, motor function, and others, That's why Alzheimer's is the first. The second disease to be tested, and already tested in some trials, is Parkinson's. And there is, and therefore I hope that maybe the FDA approval is faster than 10 years, a trial running in Harvard University. And we were at the ASMST meeting in Boston in March. And a Italian-born colleague who is a very famous neurologist at Harvard is now compiling the second TPS trial in Parkinson's. And he is pretty good looking on EEGs, seeing some normalization of the EEGs. And there is, even now scientific work on a very high level in Harvard on TPS. So hopefully if the trial is successful and then, it takes some time and submitted to the FDA, this might help in line with the broad experience from Europe and from Asia, because in Hong Kong, for example, and in other Asian states, there is a lot of work on TPS, not only in Parkinson's and Alzheimer's, but also in depression, in children with attention deficit hyperactivity syndrome and other diseases. So it is, my view, we are at the very beginning of a pretty interesting area, the brain, to be treated. And I even last year published a trial on concussion in sports, so it's very successful in concussions. So it is a very interesting, let's say, modality, I would say.
It's mind blowing. When you think it started from a kidney stone treatment to now brain, heart, and it's doing all this goodness just by stimulating the body to treat itself. But then just what I heard from you is, again, prevention, it's much more important than the cure in a way. Yes, it can be used as a cure, as a tool, but also can be used as a prevention, whether it's like, the skin, for anti-aging, whether it's for the brain, for the muscle. I want to share you this story with a client of mine, and I don't know how true it is because it was the first time ever that I had this feedback or she asked me. So I've been treating her with Shockwave for over a year, neck tension, very high level CEO, running businesses, under stress, muscle tension. And she said, Uran, I don't want to waste time to get, massage and other things. This gives me the biggest relief. I just want to keep doing this every, 2 weeks or so, or once a week. Can we do this? I said, yes. It's like we're not going anything after. We're just going to maintain, your muscles loose and range of motion and all that. Then about 2 years later, she goes just for assessment of the carotid arteries, just to see if there's any plaques build up, anything. She's 55 plus. They did check and they said, this is unusual because for your age, there must be some type of plaque build up, but there's nothing there. And then she asked me, do you think it's from all the shockwave that we have been doing? I said, you know what? In theory, it might be because yes, we used focal shockwave. We worked on the SCM to prevent, the headaches and we treated all this area. So this could be another, condition for like the future. If this is true, But do you have any idea? Could that be possible?
So there is, at least for the lower leg, there are studies out there showing that shockwaves can be quite good for obliterative or occlusive disease of the vessels. So in the moment now, if we have I was operating, I was, doing cardiothoracic and I operated some carotides. And this is the area where I would say always this is the red flag area for shockwave, because you have the vagus nerve, the vagal nerve there, and the sinus node as well. So if you have much energy or kind of stress here, you might end up with some significant heart problems immediately in an instant.
Yes. Yeah.
And therefore we, as of now, say, please avoid to place shockwaves over big vessels. And in my view, carotides are big vessels because they are more than, they are big vessels. There's a big deal. However, if you come in an indirect way, this might well be. And if we are early on, this might be interesting. And there is even a company, let's say, in the space of shockwave, who is just bought by Johnson & Johnson, I think last year, a catheter-based therapy with shockwave. So they have a very miniaturized small shockwave device inside of a catheter. And this is placed into the vessel. And then the shockwave, in a different way, like in lithotripsy, is trying to disrupt the plug. And then there is kind of a mechanism in the catheter with a suction device that the broken plug is not transcended, sucked out. then so this shockwave-based catheter, is sold for a very, very high price. Therefore, I would not be so surprised if we might, if we are early, do something good for the vessels. So then it's a problem, where to treat, when to treat,
And
when to
how.
start.
Yes.
But this is the same with osteoporosis, for example, because we had I was first time in Japan in 2017 for Shockwave, and Japan is an aging country with the most people living older than 100 years worldwide, And then they asked me, smart question, do you believe that shockwave could help in osteoporosis? And I said, yes, might well be, but problem is where to treat, what bone to treat, when to start, and now we have some trials out there, both experimental and clinical, that bone, let's say, density is increased with shockwave. We even wrote, and it's in submission, an article even for space flights. So if you are going to Mars in a space flight with either Jeff Bezos or Elon Musk's rocket, it takes you 9 months roughly. They even on the ISFs, they have the problem with anti-gravity. So gravity in a way is very essential for it. And they do training on the treadmill each and every day for 2-3 hours to get less of the effect of the anti-gravity in a way. And it would be nice in a way to consider shockwaves even on that long space flights if we could show on Earth beforehand that we might improve bone density in these exercise or studies where you do a long time bed rest, for example, 90 days. And I'm in the moment in contact with the European Space Agency, fully convincing them to start a trial, which might be the avenue and the opening door to put it then after some technical modifications in space. So I strongly believe that the shockwave machines and even the magnetic field can be pretty helpful in osteoporosis for whatever reason, in space flight or, on Earth.
Yeah. So now this is more technical question. Which one is more powerful when it comes to bone healing? Or how would you treat like osteoporosis cases or let's say non-union fracture? Do you treat it just with focal or do you combine it with EMTT? Because we didn't, like you mentioned a few times, but not many people actually know the power and what the EMTT is when it comes especially to bone healing.
Yeah, so just a few words on the EMTT. So the EMTT is a fast oscillating magnetic field. It's sounding similar to the shockwave. However, you rarely feel something. Only on some locations near the symphysis, near the plexus, sometimes in disc prolapse syndrome, you feel something, but usually on the knee, on the foot, on the hand, elbow, you rarely, even on the highest energy, you feel something. Leonard Gerdesmeyer, who is the son of Ludger Gerdesmeyer and is just working in Harvard, compiled a 3-year study on the EMTT on bone cells. So he cultivated bone cells and did 3 years of experiments with EMTT only and could show that on each and every stage of the mineralization of the bone, EMTT was very powerful and stimulated everything. But he did not a comparison with the same experiment with ESWT. I, coming from more of a clinical perspective. So I started with shockwaves and EMTT very early on bone edema in athletes and on non-union situations in 2018, 19, 20. And I found cases, humerus non-union, scaphoid non-union, metacarpal non-unions, where I did 3 treatments with shockwaves and EMTT. And interestingly, after 3 to 4 weeks, they were solid, which is much faster than expected with shockwaves only. So I see the big clue in the combination, and I would not say is shockwave better or EMTT better. They are, in my view, congenial simultaneously, because the one is working on acoustic waves, on the known cell mechanisms, and the magnetic field is inducing, because it's magnetotransduction or induction therapy. The magnetic field is inducing voltage changes in the tissue.
Yes.
And we know that in the cell, each and every part of the cell, the nucleus, the endothelium, endoplasmatic reticulum, the mitochondrium, all have different voltages on the membrane potential.
Yes.
And if you change the membrane potential, you can change the function of the cells. You have proliferating or non-proliferating cells. You might have macrophages in the immune system more on a anti-inflammatory way, M2, or more pro-inflammatory, or M1. So you change with the voltage the function of the cell. And therefore, in my view, it's pretty smart if you have both to combine.
Yes. Yeah. We literally, I'm still practicing, like treating 3 days a week. And pretty much now, as soon as there's inflammation present, it's more acute case, or any time when the person already went through the whole system, I combine it, and it's been unbelievable how much better results. And another thing that I'm seeing, it almost like suppresses a flare up after the shockwave. Like before, if I pushed a little bit more with shockwave, people the next day would be a little bit more sore. Now, since we have been doing EMTT, they almost like go straight more on healing. And my son, who every year for some reason in April is challenging the technology and me and the clinic, he goes and breaks a bone playing sports. So last year, he had a hair spring, exactly, going from hibernation to full on mode. Last year, he broke his ankle, like just a small fracture of the growth plate. And I did shockwave, and EMTT took him to emergency. They put cast literally in 3 weeks. He started breaking off the cast, like running on the cast. And then this year, just literally 2 weeks ago, playing basketball, was dunking, buccal fracture caused. So I'm just treating with the EMTT because they already put the cast on it. So I see that, firsthand. And it's truly unbelievable what we have available today as practitioners. So I want to pick your brain on this, because there's so much, especially in North America. And I've seen a lot of orthopedic surgeons use PRP, use stem cells. And I know personally, I don't do biologics. I only do the shockwave part. But when people get, PRP stem cells and they combine it with shockwave, it's working beautifully. It works much better. Another trend that I had few cases, I treat a lot of pro bodybuilders. So they use peptides in regular basis. And when it's combined with shockwave, it's way more powerful. So what is your take? What is your comment or your perspective on this?
So on the one hand, I'm aware that Steve Sampson and others on the Toby network are promoting the use of PRP with or without, or with glycosid rich or poor, depending on location. We have quite a lot of data on stem cells, adipose-derived stem cells, bone marrow stem cells, and others. The current president of the ASMST, the US American Shockwave Society, Bryce Blatz from Oregon, is doing even intraosseous bone injections in bone edema and getting better results when combining it with shockwaves and EMTT. So there is a trend. And I would say the jury is still out there on timing, dosage, and everything. But we even saw in a veterinarian trial from the US, where they did PRP from American quarter horses, 7 horses, and they counted the platelets and the growth factors before. Then they took the syringe with the PRP and shockwaved the syringe, and could show a 300% increase in the growth factors if they shockwaved the syringe, just to give you an idea where it is. So yeah, there is something. So in my view, you can precondition your tissue. So might be wise to do shockwaves at least a week before, at least once before such an orthobiological treatment. We are aware, one trial from Italy, that the hyaluronic acid receptor, CD44, is induced by shockwaves. So if you want to do hyaluronic acid for joints, for tendons, or even for the face, it might be good, in my view, to do it 1 week before you do shockwave, focus shockwave, because really we don't know whether or not it's working for CD44. And then you end up after a week maybe with more receptors. And if you have more receptors, then your agent comes and you will end up with a bigger and stronger response. So therefore, I strongly believe that it's good to have shock waves around PRP or also biological injections before and or after, similar to surgery. Similar.
Yes.
So you can, in my view, it can only add up efficacy, but then it needs dosage, regimens, and others, but I strongly believe that if you do it similar to surgery, maybe once before and 2-3 times after, you might end up with better results.
Yeah. See, okay. Thank you for sharing that. And then you touched on the aesthetic component, and I want to talk about this because you were again one of the first one, and the first one that I've heard, presenting about aesthetic use, like the shockwave use for aesthetic purposes. And as a clinic, we have been doing that, and we just stopped it since 2013. It was amazing. But one thing is we cannot compete, with Botox injections. We cannot compete with fillers. But it's interesting because I get it myself. And what I kind of called it was the graceful aging, It's like it helps you in a way. It becomes the secret weapon behind your skin and everything without putting anything on it. So what's your experience? I know you've done studies, in cellulite and for face treatments and the wrinkles. And I remember you explaining why wrinkles happen, in the forehead when the tissue it's tight. So where would you put, shockwave therapy for aesthetics? Like, where does it belong? How does it work?
So I would put it similar to my approach for example, in tendons, since shockwaves are not painful. Usually, if you have the appropriate parameters, and it's totally non-invasive. And if we say we have a patient who is seeking frown lines, I can do frown lines with combination of shockwave, or I can do botulinum toxin injections. And if it's the first time patient, sometimes for whatever reasons, they may be a bit more reluctant to an botulinum toxin injections for a number of reasons. And then this might be a very good starting point on the one hand. On the second hand, I see pretty good results, and I always combine my botulinum toxin injection with shockwave for free. So I do the botulinum, and before the botulinum, immediately before, I do 2,000 shots of shockwave. And then, interestingly, my botulinum toxin patients, I don't see that much, but those who I see come back after 5 or 6 months or even later. Because usually botulinum toxin, if you have the appropriate dosage, is lasting 3 to 4 months. Then you have to redo it because, then the receptor is done and then you have to have a new injection. And so it prolongs, a single treatment prolongs the efficacy because they are somehow working in the same direction. And that's why this is a very nice option. I saw a very interesting study from Italy, and I saw it in 2 patients as well. If you have filler complications, because it's kind of scarring and granuloma, it's hard and so on.
Yes.
And I see it myself, and there's a gentleman and plastic surgeon from Italy who showed it, that even radial pressure wave can be pretty effective in reducing the complications arise by a filler in the injection, especially if it's a permanent filler. Then you really have a very stressful situation because you cannot do that much because the permanent filler will not go away, So this is kind of an action. So I did not find time yet to study it much more in detail on my own because I'm playing around and I'm wanting to buy or invest in a 3D camera for the face, But since I just started my new practice in Vienna, which looks, by the way, pretty nice, and anti-gravity, a treadmill and other things, I could not afford at that very moment to invest in a 3D camera. But as soon as I have it, I want to start, different regimens, different parameters, and even the potential effect of EMTT on the skin, because nobody knows whether EMTT is working on wounds or on the skin. So it might well be or might not. We don't know. And the 3D camera offers a very objective way in measuring these things.
Yes. So we'll talk whenever you get to that point. We'll talk because we have that and we're not using it. And it's interesting because we thought it's like I brought that for class to show how the skin is changing internally and show the results and all that. And then they didn't care much. All they cared is like, okay, am I satisfied? Am I, reaching that point? But then for scientific evidence, for medical community and producing that, those tools are unbelievable. Unbelievable.
And one has to say, in the moment, the indication for the EMTT is musculoskeletal pain outside of the head. So if you apply EMTT on the face, on the head, and so on, you are off label. That's very important to stress in the moment. Although, we are pioneering things at work, and sometimes one has to push, as you say, the envelope, to do something new. But it's very important to communicate it in an appropriate way, because otherwise there is a shortcut of colleagues, physicians and non-physicians, to bypass science and then say we just apply it and commercialize it for hypothetic indication. And this is always problematic, I would say.
Yeah. So another question, and this is more again for medical community. So what do you want a surgeon or a medical doctor to kind of stop believing? Because we are in transition, with non-invasive regenerative therapies. We have AI now. There's so much that the whole world is changing. But then there's still a lot of medical practitioners and healthcare practitioners that are stuck kind of in old ways.
So I believe the idea of combination is intriguing. So my friend Ludger Gedesmeyer proposed the term soft tissue engineering, meaning combining shock waves, magnetic fields, laser injections might superior change or modify your tissue in a beneficial way. And I myself proposed 2-3 years ago the idea of the regenerative clockwork. So back in 2010, when I was in plastic surgery, I proposed with my chief at that point of time the reconstructive clockwork, meaning that combining at that point of time skin transplantation, perforator flaps, and other tools, artificial dermises, in a clockwork pattern with precision and coordination in a special sequence will allow you to obtain better results than with the so-called reconstructive ladder proposed in the early 80s by Canadians, Messrs. and Hay, plastic surgeons, saying if you have a soft tissue defect, start with primary closure if possible. If not, then go for a skin transplantation or regional flap, then skin transplantation, then regional flap. If not possible, then free flap. So stepwise. And now we, at that point of time, 2010, we have simultaneous devices and techniques to allow tissue or skin healing much, much faster. And that was the idea. And now I then said, okay, because in my view, it's very important to have a good precision and coordination of your machine. So it might well be that it plays a role whether you start with a laser or with the injection or with the EMTT, and appropriate dosage of each and every component, meaning the precision which is needed for building up a clockwork with magnifying glasses and things is, let's say, transferred, in my view, in this idea. And these tools help the surgeon reducing complications and improving healing times, and in the end, return to activity and return to sport. We just published a trial with Amol Saxena, Elizabeth Bondi, and others, combining shockwaves and EMTT in podiatric foot surgery, and could show a 6-week benefit. 6 weeks, faster return to
Wow.
activity with shockwaves
Yes.
and EMTT, just published, So there is strong data incoming supporting the idea that, it's good. These regenerative tools are not evil. They are only supportive and pretty helpful.
So, Karsten, I know just from your presentations in the past, you have treated so many, athletes in Germany and worldwide. And it's interesting because we have hockey, it's pretty big in Canada. We have Oilers, which is the home team. And I have so many clients, saying it's like, why Oilers are not coming at Unpain Clinic? Like, why they're not getting treated? Like, we see the results, we see the benefits. And then I had literally clients calling their doctors and saying, it's like, hey, you guys need to get into this. And they just say, we have it. And we know that they don't have that. But why, especially because to me, an athlete is it's a supercar. Teams invest in the supercar, but they're not investing on the proper maintenance. They're not investing on taking care of them. So what has been your experience? Like, is the athletes, the teams are utilizing this tool to the maximum capability or not yet?
I think there is some space left for improvement. My personal experience, treating professional soccer players for 20 years now. Oh, no, 22 years, because my first pro was in 2004 with ultrasound guided injections. In a team, given sport, soccer, ice hockey, there is kind of a hierarchy. And the more professional, the more hierarchy. And there is, for whatever reason, 1, 2, 3 team physicians and 1, 2, 3 physiotherapists in a given team. And there are, at least in Europe, and I suggest the same as in Northern America, there are at least 2 types of head team physicians. The usual type, which I saw and see still here, is who believes he and his team can manage everything. And he, in his medical fashion, is the best fashion because he's the head physician of, say, Bayern Munich.
Yes.
And then he will, in my view, not be that much open-minded to techniques he doesn't know that good. That's the one thing.
Yeah.
Then one has to acknowledge that from a team perspective, even on shockwaves, we have in the US, 15, 20 companies. They will all call them and say, I'm the best, I'm the best, I'm the best, shockwave wise, then magnetic fields, then lasers, So they have maybe, I don't know how many calls they have in each week. Then it's hard to differentiate what is good, what is not so good. And then they usually, which is okay, stay and stick to tradition, what they always did, And if they in the past did not do shockwave, they most likely usually in super sportsmen, they are very traditional because they don't want to risk anything.
Yes.
Even for expectation and things.
Yes. It's the responsibility part. Yeah. Probably.
So, and if they are not feeling good with the new techniques because they are novice, they will not promote it that much. So it really depends on, in my view, a lighthouse. If you have a very, let's say, good and competent shockwave user, sure, you will add up teams' injury rates and availabilities of the players. Sure, you will. But it's not in each and every team, I would say, even for political reasons, let's say, done in appropriate way, I would say. And it's hard because in the end, even the teams in between will not tell the other if they have kind of a beneficial machine.
Right.
It's an advantage, if the Oilers have the machine, the Vancouver Canucks will not know. Most likely, Although this was the only game I ever watched in NHL, Vancouver Canucks against, I don't know anymore, but it was very nice. But, this is, even in soccer, it's the same. If you have, this is a problem even for trials. We cannot, even in European soccer, cannot perform high-level trials on different therapeutic approaches. For example, in Champions League soccer teams, because they say it is, if my opponent, has better or letter, or I'm in the placebo group and things. So yeah, in a Alice in Wonderland world, it would be nice to have each and every team to invest in the right machines. Sure. But
Yeah.
it's complex. It's political, it's education, it's reluctance, tradition. All these, in my view, play a role.
Yeah. Very,
And
very
it's
true.
not
Because
easy to get in. Then even
yes,
if,
yeah,
for
yeah,
example, I know, some of the dealers in the US as well, if they
yes,
approach the team, oftentimes you cannot get to the head physician, but to some physiotherapists.
yes,
Then sometimes, at least in Germany, I can tell you, there's a big gap in between physiotherapist and the physician. So if the physiotherapist is proposing something, the physician will say no, not because of the machine, but because he's a
yeah,
physiotherapist. So all these plays a role.
yes, yeah,
Yeah.
yeah.
So
Very
it's
true,
not that
very
easy,
true.
but you
Yes,
know, I believe that sooner or later, and that's what I saw, even if patients from different teams came, I started with the sclerosing injections for one team. And then 2, 3 team members went to the national team. The national team spoke together. Then different teams
yes,
came and so
yes.
on. So a word of mouth is needed then in that way, and it takes some time, but sooner or later they will come. But there are still
Yes,
in practice or profession, there are early adopters or lame
yes,
ducks. They are
yes.
on a different trajectory, you say, usually, right?
Yeah.
Different time.
It's very true. I treat a lot of, that are just athletes that they just have, Ironman or bodybuilding and all that. And it's interesting when we treat them, optimize them, not necessarily just for injuries, like prevention, optimization, they always break their personal best. Like, at the clinic now we have the Shockwave, which is what we call it, the regeneration seed. It's like the foundation. We help it with the NTT. We use NESA neuromodulation to modulate the whole nervous system. And then when they combine those, it's unbelievable. Like they have less injuries. They perform better. Now with data, RR ring, Whoop, and all that, they can see how the sleep improves. So it's pretty cool. We can talk all night, and I know it's so late for you here. So I'm
It's
trying
okay.
to close it down because it's very, very exciting conversation. There are probably 2 or 3 more questions. So
Yes.
if there is a practitioner, doesn't matter what they do, and they're hearing this conversation for the first time about Shockwave, what do you recommend them? Like, how do they start? Because I've seen what you just mentioned in Europe, there's more regulation. In United States, I was in Vegas about 2 months ago at the biggest chiropractic conference. There were 4,500 chiros. I went there to sell my business model because I turned the clinic into a franchise. So my goal is to have 100 locations in North America by 2030. And I thought, okay, there was no better place than Vegas, biggest chiropractic conference there. So we go there. It didn't work at all. Like we didn't even have a single lead. And then I said, you know what? Instead of just being here at the booth, I'm just going to go and walk around. I was beyond shocked. There were 12 booths selling Shockwave devices. These salespeople there, like that they were running the booths, they had no idea what they were selling. They had no idea what tools they were doing. And now that's where for the first time I realized I put myself in the shoe of a practitioner, somebody that does not know anything about Shockwave. They're going to talk to their salespeople, whoever sells, better, they're going to give the device. They think that they're
Yeah.
getting a Shockwave device. And then they start again, usually without any training. So what is your recommendation? Just if somebody was asking you, hey, what should
Yeah.
I do?
So in the year 2026, in my view, it is much easier than 20 years ago when I started, because we now have, on the one hand, Shockwave books. We have in the level 10 publisher books on, say, shockwaves on musculoskeletal, on enthesiopathies, on neurology. I wrote it on aesthetics. I wrote one on hand surgery. So you have compilations. We have 11 or 12 books now, on the one hand. Let's say PubMed publications is quite hard, because we have seen last year or counted more than 800 publications peer reviewed in the Medline. So it's hard and impossible to follow up each and every study published in original texts. So therefore, books are quite a good way to start. Second is webinars. So webinars are provided by national societies like the ASMST, like the ISMST, like German Diges. We are now, and I just recorded it on Wednesday in Vienna, we are now doing virtual reality assisted shockwave learning, VR learning with the Meta glasses, where we will have a program with a company called Wave Vision, which is based in Austria, where you can use your Meta glasses and do a 3D immersive approach and see how Wolfi Schaden, how Carlos Leal, how Ludger Gedesmeyer and Sergetide are treating shoulders, plantar fasciitis, did face, I did hand or others. So this Wave Vision is nice because we have webinars and the 3D idea. And then in the end, in my view, and that's how I started our live workshops. So we will, and I will travel to Toronto actually next week, end of next week on Saturday and Sunday. We will have a workshop with Remington Medical in northern Toronto. The ASMST will most likely will have a meeting again in March, and the international society, the ISMST, will have their annual congress in June in Madrid, which is easily and directly accessible from the US and from Canada, from various airports. So this might be good options to dive deeper in the business and see the, let's say, the proponents over there.
Yeah, exactly.
Live and in person.
No, I've been attending ISMSTs wherever they were around the world. So I highly recommend that to any practitioner. That's where you learn, the science. That's where you get to see distributors, test machines, test devices, network with people, and it's like educate yourself before you make, decisions, because there are some machines, selling for probably $18, $90, $100,000. I remember I had this clinician in one of my classes last year when I did a class in Beverly Hills. She had some kind of shockwave device that I never heard about it. It was sold as a shockwave device, $150,000. And you could not even adjust the intensity. So it's like, whoa. So you spend a lot more on a tool first in education, educate yourself. Everything is available.
So, for example, last week we just came back from the German Diges annual meeting and the certification course, which is 6 days with 10 hours, so 60 hours. And we are lucky to have three different focus devices. So electrohydraulic by MTS Shockwave, and we have piezoelectric, Richard Wolf elevation, and we have Storz electromagnetic. So each and every participant can test the machines in the hands-on course and get an idea of what suits best. Is it bulky? Is it too loud? Is it whatever, And it's, in my view, so important to have a real personal hands-on experience before you decide what device to buy.
Exactly. So speaking of devices, when you retire, if you only have one choice, you only have one suitcase to put one device for the rest of your life, what would that be?
How big is my suitcase?
Good thing is technology is improving, so things are getting smaller.
I can tell you. I will see, and I just wrote with him today an email, and he will visit both Hanover and Austria. And we met for the first time on the ASMST meeting in Boston. So it's just, 3-4 weeks ago. And he will come over to Europe, and he has a piezoelectric device, which is not larger than my cell phone.
I've seen that. I saw that in Vegas. I saw that.
So that's why I would say, let's wait a bit, but depending on suitcase and other travel TSA regulations, we can adjust machines. But, there's a trend in which is appreciated by myself. For some techniques, it's easier. Some techniques, electrohydraulic, cannot be miniaturized for,
Correct.
let's say, engineering reasons that much. But it seems that piezo can.
Yeah.
The EMTT, we're going to see where the future will be, how small the devices can be, but there is a very high voltage coil inside the machine. So I would doubt that we will have a handheld EMTT machine with the same power, because just by dimensions, you have to have 10, 20 kilo voltage inside. Otherwise, it's not working. Yeah, but miniaturization is taking place. We saw on the ISMST meeting in Bogota a handheld device, radial, from China, without a cable, which lasted for some 20,000 shots. So my one way is to miniaturize the machines. If you are a team physician, or if you are traveling quite a lot like I'm doing, I could have my machine always with me, always. Not waiting, not to plug it in. So I have it just. So this is kind of, in my view, a very nice and pleasant idea. So I have always a machine in my reach and vicinity. So this is nice.
Yeah. Well, so last question. What should I have asked you that I did not?
I can tell you the main reasons because I'm so thankful to Shockwave is that Shockwave, in a way, changed my entire, not only professional, but also private life. First, professional-wise, I learned, I studied things, I published things, I learned, got to know both the German Diga Society and the ISMST Society, which are and created my family. So if we come together, and I met Wolfi, or I meet him every second week, we are close. So he is OP Wolfi for my Tadeu's son. So we are very, very close, and we have a family business. On the other hand, thanks to participating in a workshop in southern Austria, I learned by chance and run into my now wife. And I married her because I met her on a Shockwave meeting, and she was in the same hotel by chance, last evening for her, first evening for me, with her mom. So thanks to Shockwave, I bumped into her. We fell in love. We created and produced little Thaddeus, who is now 2.5, just get into kindergarten today. And this is because of Shockwave. So I can really emphasize, Shockwave reconstructed my entire professional and personal life. Thank you, Shockwave.
Wow. So you love Shockwave?
Somehow.
That's beautiful. Beautiful.
Yeah.
Okay, Karsten, I truly appreciate again.
Uran, I could not live without Shockwave. This is
very true. Very true. Very true. Honestly, very true. Like it's.
And I don't want to live without Shockwaves. This is
Yes. Hey, thank you again for your time. Based on this, I think we're gonna probably do another episode in the future. We'll let you experiment, recharge, and then we'll see. But for now, I truly appreciate your time and everybody who has stayed with us until this point.
Thank you very much, Uran. It was a pleasure being here, and the audience should be stimulated. If you have questions, ideas, topics, whatever, we really could redo it, because this was a non-structured way of very easy a conversation to follow. And if you want to dive deeper in some aspects and topics, we would be really happy to provide you some of this very short while talk, I would say.
Yes. Thank you again. Thank you for the great energy.
And see you in